Hey guys, so I'm just going to jump right in. I'm going to be going over respiratory emergencies and how they apply to UEMR. So let's go ahead and get started. So respiratory emergencies, they're one of the most commonly dispatched calls for all EMS agencies, and they're pretty common within UEMR as well. And they're pretty important for us. So as y'all know, after 4 to 6 minutes without oxygen, the brain tissue starts to die, right? And so it's really a matter of minutes. And that's why it's so important for UEMR. And that's where we really have the biggest impact, because we're getting there 5 to 10 minutes before RFD gets there. And that's really the minutes that are going to count in saving that patient's life. So what do we carry for respiratory emergencies? Can't really ask y'all because I'm recording this. So I'll just list them. So we have albuterol in the nebulizer, right? We have oxygen, and then we have all of the airway supplies, so like nasal cannula, non-rebreathers, BBMs, and then OPAs and NPAs. So it's really, really important that you know all those supplies, you know when they're indicated, and you know how to actually use them in the field. Okay, so I'm going to start with respiratory rates. This chart right here is just the normal respiratory rates for different ages. And then over here we have like what decreases it and what increases it, and that's pretty important for us, right? The most common one that you'll learn about is drugs, right? So we hear, especially with like opioids, right? You hear that it's a depressant, so it's a respiratory depressant. Respiratory rate's going to go down, and so you really, really, really need to pay attention to the respiratory rate when you have a possibility of an overdose or anything like that. And then, of course, like fever and exertion is going to increase the respiratory rate. And I put this chart here because it's really important to know what's normal for different ages. So, for example, don't call RFD for a 3-year-old who's breathing 28 breaths per minute because that's normal for them, but it's not normal for an adult. Okay, and then we have respiratory patterns. I'm not going to go through this entire chart. You can read this on your own time. But the biggest thing I want to point out is I have the name of it, and then I have the description of it, and I also have what it indicates. And the biggest thing on this chart is what it indicates. I could care less whether you know the name of it or not. I don't care. But you need to know what it indicates. If you see deep, rapid breathing, you need to think metabolic disease, diabetes, okay? So look through this chart, make sure you know what they indicate. If you want to learn the names, go for it, but it'll sound good when you're talking to RFD and stuff. But really, you need to know how to treat it when you see it. Okay, lung sounds. So all these pictures go with the above description of the lung sounds. And in my opinion, this is the topic that EMT school does the worst job at teaching. And it's not their fault, right? It's because you have to learn it in the field really to get a good understanding of what different lung sounds mean and how to recognize them, because it's hard when they're just being described to you and you can't really hear it. So we had our rotation. That's really the only time you maybe heard 1 or 2 of these. But I don't think any of us have heard all 4 of them, maybe a couple of us. So you really need to be able to differentiate between them, know what they indicate as well, and know how to treat them based on those indications. So for wheezing, that's probably the most common one y'all hear most. I know a lot of y'all associate that with asthma attacks, and we'll get more into that later. But that's that high-pitched sound, and it basically means the bronchioles are being constricted. So you can see in the picture below, the asthmatic bronchiole is really constricted. There's also mucus in it and inflammation, so you hear that high-pitched wheezing. Then rails and crackles, that's when there's fluid in the lungs, so fluid overload, and you'll hear like bubbling, snoring, gurgling. So that's really common in CHF and pneumonia, for example. Wheezing is also present in CHF and COPD, so don't just think it's just asthma. It can be other things as well. Then rails is common in CHF and pneumonia. Bronchi, so that's like the rattling sound, and I know the descriptions aren't doing a good job of teaching you what these sounds are, and you'll see in the next slide how I'll go about teaching that. So that's typically when there's excess mucus in the lungs. You can see in the picture it's inflamed and there's excess mucus. So that can be an indication of a lot of things. So COPD, pneumonia, bronchitis, aspiration. And then stridor's the last one. This one's fairly common in kids for a couple of reasons. So kids usually have the upper airway infections like croup and stuff like that, and we'll get into that later. But also it's an indication of an upper airway obstruction, and kids like to swallow stuff, and we'll get into that again too. But this is the high-pitched sound that it kind of sounds like a train whistle. So it can be indicative of upper airway obstruction. It's also heard in anaphylaxis sometimes, so look out for that, and then also airway burns. Okay, this is the slide I was talking about. So these are all links to YouTube videos that have the lung sounds in them for all 4. So please take a look at these. You really need to know the differences between them. So watch and listen to these videos, listen to them over and over again until you can really differentiate between them. Okay. So now we're going to get into the diseases and such. So we'll start with pneumothorax. And that is basically just a rupture in the weak spot in the pleural wall, right? So it's a collapsed lung. That's the more common term for it. And basically, if you can see in the picture here, it leads to accumulation of air in this pleural space. And so the lungs basically just collapsed. And so that vacuum pressure is lost. And it can be spontaneous or trauma-induced. And sometimes when it's spontaneous, they can end up healing themselves. So spontaneous ones are typically common with like the thin male smoker type demographic. And occasionally those heal themselves, but obviously don't go in thinking it's going to heal itself. Don't worry about it. Like treat it like it's an emergency, because it is. And then of course they can be trauma-induced with chest injuries and stuff. So signs and symptoms for pneumothorax, obviously there's going to be dyspnea. They might complain of a sharp chest pain as well. The really common one is unequal chest rise and fall, because only one lung is working how it should and the other is collapsed. And so one's going to be rising a lot more than the other. And again, with the breath sounds, make sure you're also taking with these patients, because when you listen to the breath sounds, one's going to be absent. And I know there are some of you who you put your stethoscope up on a patient and you're listening to breath sounds, but you're not really listening. You can't really hear anything, and so you're just like, it's fine, I can't hear anything. No, you need to make sure that you hear something, because if you don't hear anything, that's not normal. So if you can't hear something, get everyone around you to be quiet, do what you need to do, because it's important to recognize if there's absent breath sounds. That's a big deal. It's really important. And then lastly, low pulse ox, of course. Anytime you have a low pulse ox, under 94, you're going to treat that with high flow O2. That's really the only thing we can do for pneumothorax calls. And obviously, if there's any indications of it, you're going to have RFT en route, so rapid transport. And then lastly, just maintain the ABCs like you've learned to do in EMT school. Every single one of these, you'll see I put maintain ABCs at the bottom, because it's the most important thing, and it all comes back to that. Okay, airway infections. So this includes everything from bronchitis, TB, diphtheria, pneumonia, epiglottitis, croup, and influenza. There's a bunch more, but these are the really common ones. The biggest thing, I have it in caps and bold on here, it's an infection, right? And so it's an airway infection. It has the possibility of being airborne. So just be cautious. Don't stick your face in the patient's mouth to look in there, because there's a possibility of you getting the infection too, right? So wear protection, like a mask or something, and don't be dumb about it. Signs and symptoms. They might have dyspnea. You might hear that stridor like I was talking about. That's really common with upper airway infections like croup. And since they're having difficulty breathing, or they're going to be in that sniffing position, and then you might also see angioedema. So there really isn't that much we can do for infections. We don't have the treatment. That's more of a hospital situation, right? So our job is to look for abnormal vital signs and respond appropriately according to them. Fever is the big one with infections, as you know. So if it's above 101, according to our protocols, you need a captain. Above 103, you need RFD. Don't forget that. Anytime there's possibility of infection, make sure you're getting a temperature. And then again, if there's difficulty breathing and the pulse ox is below 94, like always, our treatment's going to be oxygen. And you'll need a captain approval for a refusal, unless there's respiratory distress, in which RFD is going to be called no matter what. And again, manage the ABCs always. Don't forget about them, and give O2 as necessary. And then some infections that cause inflammation also can block the airway. So again, with the ABCs, the airway portion of that, it can get blocked because of inflammation. So keep an eye out for that as well. All right, the one that you all have been expecting, asthma attack. Okay, so it's basically just bronchoconstriction and excess mucus, right, in the bronchioles. And so patients are going to be coughing, wheezing, like that's probably the most common thing is the wheezing. That's what you hear about. And they may have dyspnea or they might be apneic. They can be exercise induced or allergy induced, but they aren't always. So don't just assume because it happened in the middle of the night that it could be asthma because nothing brought it about. It can happen while they're just sleeping. And this is one of our most common respiratory emergencies in all EMS agencies. So you really have to be able to recognize it quickly. So the signs and symptoms that are going to help you recognize it. Wheezing is the most common one, of course. They might have some chest tightness and then difficulty breathing, just because the bronchioles are constricted, it's hard to get air in. And that could lead to a low pulse ox as well. They might also have a tired, lethargic look to them. So treatment, you got to know the treatment for asthma attacks. You got to know the dose. So albuterol, of course, 2.5 milligrams, and then nebulizer. And it's all great if you know that, but if you don't know how to actually administer it, then none of that matters. So make sure you've practiced administering it. You can do it in a heartbeat without even thinking about it. You got to get really good at that. So for asthma attacks, you can repeat every 5 minutes for up to 3 total doses. Unless there's volume overload like Rales, CHF, pulmonary edema, we'll get into those later. And according to the new protocols, we are going to give them a dose still, but we're only going to give 1 dose to them. And then monitor vital signs and maintain ABCs. So reassessment's really key with asthma attacks because it's going to indicate whether or not another dose is needed. And usually after you finish 1 dose, RFD is going to be there. So you're not likely going to administer another, but just keep an eye on the patient. And then again, place them in a position of comfort. Don't forget about that. Don't keep them laying flat on the ground if that's not comfortable for them, because they may not speak up about it because they see you as an authority figure. So if you see them in a position that doesn't look super comfortable, sit them up, have them sit how it's comfortable for them, unless of course there's trauma. Okay, pulmonary edema, that's basically just fluid overload, like fluid buildup in the lungs and the alveoli. So in this picture over here, you can see the fluid kind of building up. And it's basically when the heart muscle can't effectively circulate the blood. And this is really common in CHF patients, which is very common in the elderly population. So you keep an eye out for this when you have respiratory call for a geriatric patient. Signs and symptoms, you'll hear Rales. That's very common. Dyspnea again, and they might also have JVD present. So keep an eye out for those. This is why it's really important to know the different diseases and know what signs indicate them, because you may not know that it's CHF and you see JVD, and then that's a big trigger that it should be. Of course, treatment's going to stay the same. Pulse ox is going to determine the oxygen rate. And since there's fluid in the lung, some of it may come up, so suction if necessary. That may not always be the case though. Again, can't say it enough, maintain ABCs, make sure that airway's patent and all that stuff. Keep them in a comfortable position, and you're probably going to want RFD for these kind of calls. Another thing to keep in mind, albuterol can make it worse, like I said before. So before we wouldn't administer any, but now we're going to administer 1 dose. And this is why we absolutely need to be able to distinguish lung sounds, right? Because if you heard Rales and you know that there's fluid in the lungs, but you also heard wheezing, then you wouldn't administer albuterol multiple times because Rales indicates CHF, which is a contraindication for albuterol. So we just give 1 dose in that case if there's wheezing. Okay, COPD. This is fairly common, especially in the elderly population again. It's 4th leading cause of death, so it's very possible that we could get a COPD call at UEMR, especially with the professor population. It's frequently caused by smoking, and it's basically dilation and disruption of the alveoli. So you can see here with the emphysema, it's basically just really damaged alveoli. And the treatment's going to stay the same for most of these. If there's wheezing, you're going to give albuterol. If there's Rales, you're going to give O2. And again, you're likely going to need RFD for these kinds of calls. There are two different types, chronic bronchitis and pulmonary emphysema. They're going to present very differently. So this guy up here has probably got a pulmonary emphysema. He's got that thin barrel chest that you hear about in EMT school. You're more likely to hear rhonchi with these patients than wheezing or rales. And then for chronic bronchitis, which is basically just like a lot of mucus, you're likely to hear wheezing and rales. You would administer, if you heard wheezing, a dose of albuterol and then oxygen if there's rales. They might also present hypertensive and then with JVD, like the CHF patients. Okay, I'm not going to go through this entire chart. This is basically just summarizing the last two slides in a chart. Here you have all the things you'd determine in an assessment, and then differentiating between them with the three different COPD and CHF. So look through this, get familiar with it. You need to be able to distinguish between them for proper treatment, for sure. Okay, this is the big one, pulmonary embolism. You gotta know what this is, and you need to know the indications for it. This is a really scary one. So basically, pulmonary embolism is when a blood clot is formed, and it flows up to the pulmonary artery, and it basically is going to decrease blood flow. So the signs and symptoms are really big for this. If you look at their chests, there's a possibility that there's going to be that line of demarcation. You probably heard about that in EMT school, so don't forget these things because they can be very indicative of really serious problems. They might complain of tight chest pain. They might be tachypnic, right? So they might be hyperventilating and they might have tight chest pain. What does that sound like? Well, because it's more common for us, we might go and say, hey, that's an anxiety attack. They're hyperventilating. They have tight chest pain, anxiety. Don't worry about it. You got to look at the other signs and symptoms. So if they're hypoxic, if they're cyanotic because they're hypoxic, if they're coughing up blood, that should be a very obvious indicator that it's not an anxiety attack, but that's not always going to be present. So look out for the small signs. And PE, they can be very, very, very life-threatening in a matter of just seconds. The patient can die any second with PE. And so you really have to be prepared for CPR. So our treatment, high flow O2, and then again, just be ready to do CPR if it's needed. And just do not rule it out when you see a patient that presents with anxiety-like symptoms. Look out for any abnormal vital signs. Ask about history too. That's probably the biggest thing with these patients is you need to get a good history from them. You need to find out what they were doing before, if they had pain anywhere else, right? Because they could have, for example, DVT, deep vein thrombosis, and that could be like in their leg or something. They could have been on a long flight and they stood up and they had this really painful sensation in their leg, and then they call, and then that clot ends up traveling up to the pulmonary artery. Then you have a PE, and if you don't treat it like a PE, they could go into cardiac arrest really quickly. So got to get a good history on these patients. Ask as much as you can. Okay, and then anxiety attacks. So if you've ruled out PE and you know it's an anxiety attack, signs and symptoms of that, they're going to have chest pain. It's going to be that tight chest pain, not really as much of a pressure. The respiratory rate's going to be elevated because they might be hyperventilating. And then, of course, they're going to be anxious. They'll probably have a history of anxiety as well. If they don't assume it's not, because they could not have a history and still be having an anxiety attack. So these kind of calls are really where communication and patient interaction skills are sometimes more valuable than the clinical aspect of treatment. So really just use common sense. If they're surrounded by people and noise, get them out. So if they're at a basketball game and they're having an anxiety attack, take them out into the hall. Don't try and treat them where it's super loud and there's people everywhere. Also, if you being close to them is making them more anxious, step back. If they like one provider better than you, don't get offended. Let the other provider treat the patient. Do what's best for the patient and pay attention to what's helping and what's not. For hyperventilation, have them mimic your breathing. So breathe at a normal rate and deep breaths and have them try and mimic that. So yeah, biggest things, de-escalation for these patients. There's not much more we can do. If they're hypoxic, then yeah, we're going to give them oxygen. but they're probably hypoxic because they're hyperventilating. So if we can stop that hyperventilation, we'll be in a good position. And if we can't de-escalate, you might have to call RFD. So keep that in mind as well. All right, pediatrics is next. Biggest thing, this is like the Bible of pediatric assessment, right? The pediatric assessment triangle. You gotta have this memorized. This is super, super important with any pediatric call. So there's 3 parts to the triangle, of course. There's the breathing part. So you're listening to breath sounds, positions, if they have nasal flaring, things like that. And then circulation, so cyanosis, if they're really pale, clammy, anything like that. And then appearance of tone. Are they crying? Are they not crying? Are they gazing off into the distance, or are they interacting with you? So those are the things you need to be looking for. And if any of those are abnormal, then if you look over here, you can see what those indicate for a pediatric patient. So it's different than an adult. This is only going to be used for pediatrics. So if all components are normal, then the patient's considered to be stable. If breathing is abnormal, if they have abnormal breath sounds, then that's going to be considered respiratory distress. But if they have, for example, abnormal breath sounds and also appearance is abnormal, then we're going to consider that respiratory failure. If circulation and appearance is abnormal, we're going to consider that shock. If just the appearance is abnormal, that might be a CNS or a metabolic issue. And if all components are abnormal together, that's cardiopulmonary failure. So make sure you know what the combinations indicate and what they indicate by themselves. So children act a lot different than adults when they're sick. Kids should be crying. If they're in pain, they should be crying. If they're not crying and they should be, that's what's concerning. You shouldn't be like, oh, okay, they're not crying. No, if they're not crying, that's concerning. So this triangle's really got to be memorized and should be used on all pediatric calls, not just respiratory emergencies. Use it on everything that you do with pediatrics. Also, adults make it very clear when they're sick or about to die. They're going to be like, hey, stupid, I'm dying, help. But kids, it's not as obvious. They compensate really, really well, and then they drop rapidly. So you need to pay attention to the really subtle signs and act accordingly with those. So memorize that triangle. Okay, airway obstructions. So there's 2 different obstructions that I'm going to talk about, upper and lower airway. With the upper airway, that's when you're going to hear the stridor, so that high-pitched sound. And that's really common in croup. Lower airway is more like wheezing and rales. So croup's basically just a viral infection below the vocal cord. So this is what it looks like here. There's just swelling, and so it narrows the airway, which is why you hear that high-pitched sound. It's really common in kids. Really common in kids. And it can also trigger an asthma attack, so keep that in mind. And also, we're not going to administer albuterol. For airway obstructions that are just like if they swallowed a penny or something, you're going to encourage them to cough and clear the airway. And if they go unconscious, you know your protocol for that. Start your CPR if they're pulseless, according to those protocols. So airway obstructions are one of the most common pediatric respiratory emergencies, just because kids are really curious and they like to put things in their mouth and they can easily choke on them. And infections are also really common because kids are messy and they go to elementary school and all that stuff. So this applies to upper and lower airway obstructions. Okay, this is the last slide I have, and these are the main takeaways from this presentation. So just because you hear wheezing, don't assume that's asthma. It can be indicative of a lot of other things like we talked about. It's present in a bunch of different things. So don't just assume they're having an asthma attack. You need to get a good history on these patients and also consider the demographic, right? Asthma is more common in younger kids. I mean, don't assume it's not present, but it is more common in younger kids where COPD and CHF and stuff like that are more common in the elderly population. Also, abnormal lung sounds are not always wheezing. If you hear abnormal lung sounds, don't just assume it's wheezing. This is why you really, 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 really need to know the difference between the lung sounds. So please listen to those videos, know the difference, because it's extremely important, because what they indicate is going to determine how you're going to treat that patient. And if you treat it like it's wheezing and you give them multiple doses of albuterol, you're first of all violating our protocols, and you could really harm the patient doing that. So you need to know the differences. Respiratory emergencies can be very subtle as well, so you have to know the signs and symptoms to look out for. This is especially true in pediatrics, but also in adults. So like I said, for PE, it may just look like an anxiety attack, and you got to get a good history. You got to check the vital signs, look for the line of demarcation, stuff like that. Like I said before, children and adults will be assessed very differently, and the differences are important. So you're going to use that pediatric assessment triangle on all the children, and adults you assess like we've learned. Also, don't just look for pulse ox and respiratory rate. You need to look for other things that aren't necessarily indicative of a respiratory emergency. It's not the first thing you think of. So JVD, right? Demarcations, like I said, for PE, anxiety and chest pain, also for PE, those are all indicative of really serious emergencies. And if you just focus on the pulse ox, then that can literally kill them. Also, guys, I'm pointing this out because I think it's really important. You need to be super familiar with our equipment. This doesn't just apply to attendants, this is everyone. If you aren't super comfortable putting together a nebulizer, do it next time you're in the office. If you kind of forgot how to measure an OPA or an NPA, or what the lube looks like, where you're supposed to apply it, how to insert them, go practice now. Don't wait. Don't be shy or embarrassed that you don't remember, because you can forget. Even if you learned it when you started here at UEMR, you can forget it next year because we don't really use it very often. But if you don't remember something, go practice, because it's better to mess up when you're practicing than go out into the field not knowing what you're doing on a call and do something really bad to the patient. So please get super familiar with everything in our equipment bags. And then this is a big one. Respiratory emergencies are one of the emergencies we are most equipped for. We have oxygen, we have albuterol, we have OPAs, MPAs, we have all that stuff, BVMs, everything. But they can go very wrong very quickly if we do not act quickly and accurately. So you need to pay attention to the small signs and symptoms that can be indicative of certain respiratory emergencies. And then, of course, like I've said 100 times, don't get distracted from maintaining the ABCs. If you're looking for something in an assessment and they're not breathing, like put them on oxygen. Don't hesitate to do that while you're trying to assess. Don't get a history while they're having difficulty breathing. The first thing you need to do is put them on oxygen if they have difficulty breathing. So prioritize the ABCs always. And that's all I have. So thank you guys. If you have questions, let me know.